The recording will be available for you if you want to look at it later. So just remember it's being recorded. Yeah, welcome to this chilly Joburg evening on my side. Let's maybe just start with just a bit of a landing practice. So just taking a moment to maybe look around the room, just placing yourself in the space you're in. And maybe you take a little bit of a deeper breath. Maybe you need a bit of a stretch, whatever you need just to land in the space. And maybe just having a thought about anything that you need for your comfort. If you are struggling with pain, do you need some pillows? Do you need some blankets? Do you need a dog on your lap? And if you'd like to, closing the eyes. And just taking a moment to feel the feet on the ground, the bum on the seat or cushion. And just allowing yourself to land in the gentle embrace of gravity and the earth. And widening, just feeling the sense of the whole body on the seat. The sense of settling down for the next 1.5 hours as we journey through mindfulness and pain management and recovery. Sabbaths, 1979, by Wendell Berry. I go among trees and sit still. All my stirring becomes quiet around me like circles on water. My tasks lie in their places where I left them, asleep like cattle. Then what is afraid of me comes and lives a while in my sight. What it fears in me leaves me, and the fear of me leaves it. It sings and I hear its song. Then what I'm afraid of comes, I live for a while in its sight. What I fear in it leaves it, and the fear of it leaves me. It sings and I hear its song. After days of labor, mute in my consternations, I hear my song at last and I sing it. As we sing, the day turns, the trees move. Welcome, everyone. Maybe just taking a while just to open the gallery view and just welcoming all the faces that are joining us tonight. And yeah, we're just going to start with some introductions. So I'm Ivo Visic. I'm a physiotherapist in Johannesburg. I work in a few different areas of physio. So I work from the ICU in hospital. I do a lot of home visits, and I also do end of life and hospice care. And I have a private practice at home where I work with people with chronic pain and trauma and all the bits and bobs that physios see as well. And yeah, I've been teaching with Tracy. We just did our 10th MVSR. So yeah, we've been doing that work now for about 4 years, teaching to health professionals. Yeah, and that's me. Tracy?
Thanks, Ivo. Yes, so something that I do is I teach with Ivo as a mindfulness teacher, but I'm also a physiotherapist. And my journey over the last 30 years has taken me towards working with people that are struggling with their bodies physically, fatigue, pain, dizziness, chronic autoimmune diseases, pretty much anything that feels unpleasant in the body. And over the last 30 years, I have been taking on more of a body-mind, mind-body approach to helping address these issues. And I suppose more recently, in the last 4 or 5 years, I've become very much interested in trauma and the effect that trauma has on these various challenges. And so I'm also currently training to become a somatic experiencing practitioner. So using a somatic approach to helping process trauma that is stored in the body. And then I very much day to day help people with chronic pain. And that's what we'll be talking about today. So yes, Lisa, I'll hand over to you because I think Lisa uses also quite a few of the different techniques that I use for that.
Yes, so I'm Lisa, and I work one-on-one and in small groups with a variety of modalities, also for people who've come to that point in their journey where they're open to and are ready for the mind-body approach, where they're, you know, the pills and the surgeries and the running around for many answers hasn't delivered, and there's an openness to a journey into this world of working more holistically. And the modalities that I use are obviously mindfulness, so the most important, the holder, the container. I also work with a movement practice called clinical somatic movement, which is for releasing chronic muscular tension, which is a big part, you know, driver of the chronic pain picture. I also I'm very interested in dance and movement and expression as a way of working with pain. And I also have a certification, just a small certification, but a real interest in pain reprocessing therapy, which we'll talk a little bit more about. But yeah, that's my practice.
Thank you. So, Ivo, do you want to maybe get it's a very brief PowerPoint. Don't worry, everyone. I'm not going to bore you with a whole lot of PowerPoint slides, but we thought it would be very helpful to start today by going through some of the neuroscience around pain. So I'm the lucky one that gets to describe and explain this to you, but I'm just going to give Ivo a little moment. And then will I go up, will my face come up next to the PowerPoint? No, or will it just be a voice in the background? I think it might just be a voice.
No, it should come up.
Oh, should it come up?
Depends
Okay.
on people's settings on their side.
Okay.
So, there we go.
Cool, thank you. And then I'll just tell you, Ivo, when to click. Okay, cool. Okay, so I'm going to try and, I don't really like looking at slides, so I'm going to try and explain it more from my heart and from my understanding. But I think that what's really important to understand before we even get going with mindfulness is that the understanding of pain has changed tremendously from a neuroscientific point in the last 15 years or so. So originally, when I was at university, we were taught that pain comes from special pain receptors in the body. And when something happens that is dangerous, those pain receptors get triggered and a pain signal travels up to the brain. The brain then registers the pain signal and then you feel pain. So in other words, we were taught that pain was an input. And that's really how a lot of biomedical medicine, it's based on that knowledge. And many doctors and other health professionals still hold that outdated belief, because it really is a belief now, it's not a fact. So what we now understand, thanks to the neuroscientists that have been working on the subject for the last 10, 15 years, is that pain is actually an output of the brain. It's not an input. In other words, it's not actually a direct measure of what's happening in the tissues of the body. Pain is actually an output of the brain, as is many other experiences that we experience as human beings. So, for example, vision. As you're looking at, maybe there's a cushion in the background in your room, and it's the color blue. We now know that that blue signal is not being sent from the pillow to your retina, and then the blue signal is being sent up to your brain for processing. What's actually happening is there's data that is arriving at your brain. Your brain is then making sense of that data, weighing it up against previous data that it knows and understands about color, and then it spits out this experience, and we see, or we experience, that pillow as being blue. And I'm sure many of you have also had have had little fun examples playing around with vision, with optical illusions, where maybe someone shows you a piece of paper and you can see some weird things moving on the piece of paper. Now, no matter how much you can look at that piece of paper, and even though you know there's nothing actually moving on that piece of paper, your brain is making you experience that image as moving. And that is because the data that is being received by the brain is being processed and interpreted and weighed up against previous data that it knows and understands about shape and color and shading and lighting. And it weighs it all up, and it usually will weight more heavily your previous experiences of that kind of visual data. And then it spits out this response. It spits out an output, which is, I see that picture as moving. And that's the same thing with pain, is that it's a sort of the net result of a series of processes that are happening in the brain at any given moment. So when we are experiencing physical pain, let's say in your left elbow, what we know is that your brain is making you experience that feeling of pain, and it is doing that, it is making that experience because in that moment, it's the most wisest thing to do. It's protective. So we say that pain is protective. And the reason why you're feeling pain on that left elbow is maybe because you've been leaning on it for a long time, and there's some danger messages that are starting to be triggered at your elbow, and that danger message is coming up to your brain for processing, and your brain's weighing it up, and it's going, well, what happened the last time we were leaning on the elbow? And maybe in your history, the last time you had anything happen to your elbow, you knocked it. Maybe you knocked it against a wall, or you had an injury 10 years ago when you were playing rugby, or maybe you were working really hard at your desk yesterday and you spent way too long in a very stressful situation, leaning on your elbow, trying to figure something out at your computer. So it's taking all of that available evidence, or that data that it knows about you and your behavior, and it weighs it up and it goes, well, is this current data that I'm receiving from the elbow, this sensory data that I'm receiving from this left elbow right now, is it dangerous or is it safe? So it weighs it up, all of those safety cues or dangerous cues, and it tries to work out what's the safest, what's the best thing to do to keep this organism safe right now. And perhaps if there is a little bit of a history there, or even if there's not a history there, if you really are leaning on that elbow very hard, and in the current situation, it's getting quite dangerous, you're starting to risk the health of the tissues in the elbow, the brain will then go, and it sort of triggers this alarm system. And that alarm system we feel as pain. So pain is a little bit like an alarm system, alerting you to, hey, pay attention, change your behavior, do something differently. And so the main take-home message in that second point is to understand that it's protective, pain is protective, and it's the brain's way of reacting to perceived danger. Now, we say perceived danger because remembering it's not only about what's happening in the moment, which might be dangerous, I'm leaning on my elbow too hard, but it's also weighing it up against, well, what's happened in the past. And so because of that, because we're at the mercy of our history, of our past, it means that the system, the pain system, can actually get a little bit extra sensitive, especially when it comes to my left elbow, because I had that injury last year, and when I fractured it and I was in the car accident, every time I do anything that might suggest I'm going to injure or maybe even bruise or even put a little bit of pressure on that elbow, the brain will perceive that data as being dangerous because it's weighing it up against the previous data. So okay, well, I won't get into mindfulness just yet, but I'll explain why mindfulness is so helpful in these moments. But the main thing to also understand then is that because it's weighing up in the moment, is this safe? Is this dangerous? Is it safe? Is it dangerous? And it's trying to kind of get a sense of what it should do in that moment. What we know is that in the moment, as you're experiencing that pain, or as you start noticing there's something uncomfortable in my elbow, if you fear that pain, and if you try to fight the pain, or if you try to even fix the pain, or if you try to, I always call them the 5 Fs. If we're ramping up our, if our sympathetic nervous system or our emotional system is being ramped up in response to that experience of pain, we know that it can sort of feed into the pain cycle. And of course, then the danger, the threat level goes up. There's more danger, so the brain's triggered into making more pain. So thoughts, beliefs, emotions, past experiences, plus the environment that we're in can all influence how much pain we're having in the moment. So we know that things can amplify pain and things can soften the pain experience. So we can say that pain is modulated at brain level by all these different things. Okay, I hope that's all made sense so far. Okay, so the other thing to understand is, I think I've already said the first point, that it's the assessment of safety versus threat, but also just to understand that it's contextual. And what I mean by that is, in the second point, one might think, well, how in the absence of injury can pain still occur? And I'm sure I can maybe just invite you all to cast your minds to a situation that you can relate to where this has perhaps happened. So I'll give a little quick story. It'll take 1 minute of something that happened to me, and then maybe you can think about in your own life if this has happened. So a few years ago, I went for a run and I had to duck under a bush, and I got scratched on my neck by the bush. And by the time I got home, it was about another 5 minutes to go. My neck was feeling quite sore. In the moment, it didn't feel so sore, but by the time I got home, it was actually very painful. And it felt a bit swollen. So I asked my husband to have a look. And he's like, oh, well, you've been stung by a bee. So he pulled out the sting. And I said, well, actually, I think I need to go to the doctor because I'm allergic to bees. So off I ran, drove to the doctor, got an injection. The doctor said, listen, whatever you do, don't get stung by a bee again because it's actually quite dangerous. Anyway, lo and behold, fast forward about 3 years, I was hiking in the mountain and we got to a section under some trees where there were a whole lot of where the bees, beehives, where the bees make honey, beehives. And I looked at this and I thought, oh gosh, I've got to get through this. And I said to my friend, listen, I'm actually allergic to bees and I'm a little bit scared right now. And she said, oh, you must just relax. The bees will pick up if you're scared. So then you must just try and relax. So I'm trying to relax, but not really doing very well. And then we had to kind of bundu bash to get to the path section. And we had to go over some scrub. And as we walked, I was in shorts. As we walked, I felt the most searing pain in my leg. And in that moment, I sort of collapsed down because it was so painful. I couldn't understand. I didn't even think about what it could be. I just knew that my leg was in trouble. So I sat down, looked down, and expecting to see blood everywhere or expecting to see bees sitting on my leg. I hadn't really thought about what it was, but I just was expecting to see something very damaging and terrible happening in my tissues. And lo and behold, there was just this tiny little scratch. And I actually had a moment of realizing, this is my brain really trying to protect me, because in that moment, there was just so many threats going on in my body that little scratch was considered to be very, very dangerous. So what had happened 3-4 years ago earlier had actually been dangerous, but I didn't really feel much pain in the moment because my brain at that time hadn't perceived it to be threatening. And then fast forward 4 years, tiny, tiny tissue damage, big pain response. Now, I've been scratched many times. I like gardening. I like pruning roses. I mean, I've walked back in after an afternoon of pruning roses and I'm covered in scratches and I haven't felt one of them. So you kind of can ask yourself, well, when has that happened where you've had tissue damage, scratches, no pain whatsoever because you're having fun, you're hiking, you're doing stuff, you're relaxed, versus maybe when you're like me, scared of snakes, scared of bees, and you get a little tiny scratch when you're walking in the veld and it's very painful. And that's because the brain is just trying to figure out, in this context, is this dangerous or isn't it? So you can get various degrees of tissue damage, sometimes even no tissue damage at all, and a big pain response. And then vice versa, you can actually get sort of really no pain and actually quite a lot of tissue damage and quite a dangerous situation like what happened with my bee sting. Okay, I think the next, okay, so I just wanted to kind of just show you a way of explaining this by showing you something called the protectometer, which is sort of like a thermometer that's, well, it's a metaphor for a thermometer that helps us to, or helps our brains to measure, well, in this moment, how much protection do you need? How much pain do I need to make in this moment? It was developed by Lorimer Moseley and David Butler, who are two pain scientists, and they're part of the NOI group, NOI, Neuro-Orthopedic Institute group. So let's just go onto the protectometer. I'll just show you. It's actually just a picture. Oh, sorry. Can you go on? There we are. We'll go back to that in a moment. Okay, so this is, I use this pretty much daily because it's a very nice visual way of understanding that in any given moment, you can have these experiences. As I said, you know, I work a lot with fatigue, chronic fatigue as well. Also people just with a lot of bodily felt anxiety. And it's the same thing. It's pretty much anything that even dizziness is produced by the brain, even feeling nauseous, vomiting. I'm working with a child that can't stop vomiting at the moment. So all of these things we think of as being direct, sort of, you're vomiting because you've got something in your stomach that needs to be gotten rid of, which is all very well and good in the beginning. But actually what can happen is the nervous system can get so wound up that it can actually start triggering a vomiting response even, or nausea, even when there's nothing really that's harmful in the belly in that moment. So we can use this concept of a protectometer for all of these outputs of the brain. And you can imagine that if there's lots of what I call them SIMs, safety in me, which are sort of the sense or the feeling of safety. And if there's lots and lots of safety going on in any given moment and not a lot of danger, the protectometer is sort of more lean. I always think of those old-fashioned scales, you know, where you put the weights on the one side and then you put the weights on the other side. And I always think of like which way is the scale leaning. And so if there's lots of safety, it's leaning more towards safety. So the nervous system's less inclined to need to make pain. So you can actually have something going on. If you look at the one category, things happening in my body. So maybe you could have something going on in your body in any given moment. Let's say a bit of inflammation. I don't know about who's hormonal and who's menopausal in the room, but I am. And I do know that there's more inflammation going on in my body right now. So I can have that inflammation going on, a pro-inflammatory state, maybe in my joints in any given moment. But then because I'm maybe doing things that feel safe to me, like surfing and hiking and yoga and all the things I love to do, and I'm hanging out at places that give me great joy, and I'm surrounding myself by people that help me to feel safe, and I'm saying things like, this is a phase of life and it's okay. And even though I've got a bit of aching joints, I know that it's going to be, you know, that I'm going to be all right. So I can say things to myself. They're things that I think and believe about this phase of life that's very safety making for me. And then I also can support myself with things that I do that might support me as I'm navigating my menopausal journey, such as strength training or such as practicing more my mindfulness. and doing lovely, gentle things for myself that feel very compassionate, like making sure I get enough sleep, putting my nice face cream on and smelling my beautiful essential oils in the evening. So that's just me giving you guys a little example of how the protector meter works. But you can imagine if maybe I'm going through a really stressful time and I'm not getting enough time to do all of those things, and I'm working hard, and there's really tricky people that are in my life at that time, and I'm feeling very overwhelmed, and I'm worried that I'm not going to be able to cope with what I'm dealing with, then the scale is going to tip towards danger. And that thing that was happening in my body last week, inflammation, now, because of all the danger on that side, things are going to start tilting towards danger, and I will maybe start getting more pain in my joints. The pain levels might go up, or it might get out of hand even, and I might have all over body pain. Okay, so that's, I'm hoping that's given everyone a fairly good idea of as to how the neuroscience of pain works. But then if you go back maybe one, Ivo can maybe just explain to you now how that all kind of fits in with mindfulness in terms of reappraisal of pain. And yeah, I think I'm just going to hand over to Ivo for a little bit to just explain how mindfulness fits in.
Yes, Al, this is a diagram I found quite a while ago, and it really puts into perspective what happens with mindfulness as we use it to positively reappraise pain and to find our relationship with pain. So on the right, you'll see the downward spirals. So we have some sort of pain issue, and we get that attentional fixation and rumination. So we start to really fixate on it. We really give it a lot of attention, a lot of energy, and then we have a lot of thoughts about that. This shouldn't be happening to me. Why is this going on so long? I've gone to all these doctors. And over time, obviously, this creates this downward spiral, um, which can, lead to addiction in the end if somebody's not controlling their pain. And over time, this will also increase the sensitivity to pain. So, like Tracy was saying, um, over time, if you constantly have this sort of traumatic response to pain and you're more on the DIMS side, the danger in me side, then your sensitivity to pain will increase. And then this leads to sort of identifying with the pain, and the pain almost uh, becomes yourself because it's so all-encompassing. And then this leads to this downward spiral. And over time, I always like that insensitivity to natural reward is you can even start to not even, it becomes hard to access the sims. So a lot of work in chronic pain can be just like to access those safety spaces within and to start to realize like, oh, wait, this is a resource, this is a resource, this is a safe place. And on the left there, you'll see we have stress appraisal. So just going, oh, I have pain. There's something that's stressing me. There's something that's traumatizing me. We decenter from it, so we don't identify it. We, like I say, with mindfulness, giving it a little bit of space, just taking that little backward step to go like, what is my relationship to this? What is happening here? Instead of that reactive response. Um, then we have a state of mindfulness, so we give it space. And then we might positively appraise it. We might go, oh, okay, wait, is my body trying to tell me something? Is there something that I can do to respond to this pain instead of just clenching around it? So over time, it can decrease stress and we can start to engender those SIMs that we need in order to work with the chronic pain. And then this obviously becomes an upward spiral, and our attention can also broaden. So if you give your pain 90% of your attention, then it's sort of 90% of who you identify with, which a lot of chronic pain people say it just takes over their whole lives. So with that attentional broadening, then there's also this sort of pain is then maybe 10% of your attention or your awareness. So it gives it a lot more space. So it's not taking up your entire attentional broadband. So this is how mindfulness starts to slowly create the space where you can respond and give that pain more space and then allow yourself to access these different things that can help with modulating pain within the body. And then the last part, I'm going to show a little video. And this is just a lovely video to show do you want to do that last slide? Or have you mostly spoken to it?
Um, yeah, actually, no, I'll quickly just mention that I think the big thing for me when I started, and I'm sure Lisa will speak about this as well, but the big thing for me when I started learning about mindfulness and understanding how that might fit in with pain management and pain treatment was that it's absolutely essential that the person first feels safe. So if they constantly are worried that this pain is indicative of something is wrong in my body and I'm literally in danger of dying or of something going on in my body that's going to ultimately kill me, because that's really why pain exists, is to keep us alive and surviving as organisms. So I always explain that it's really important that the understanding about pain is so important. But if there's a doubt, if someone's really saying, yeah, but you know what, maybe they missed something, maybe I actually do have cancer, and this pain is actually warning me about the fact that I've got cancer, I always suggest that people go and make sure that they get the appropriate investigations done so that they can get to the point where they can say, the doctors have looked, they've covered everything, they've told me that my tissues are safe. And even some people come to me and definitely to Ivo as well about, maybe you've been told that the tissues aren't safe. In other words, I've got osteoarthritis of my neck, but there's nothing that they can do for me. Then what I would need to work on with that person is understanding how pain can be modulated by those beliefs about the tissue safety. So it can get a little bit more complex and a little bit more layered when we start dealing with musculoskeletal diagnoses. But I think the main take-home message is that if we can really work with the fear around the pain and what that means, then mindfulness can really help us to start noticing how maybe how we are reacting in that moment, where our thoughts are going, what are our beliefs in that moment. And as if someone can understand that that's going to modulate their pain experience, we can start untangling that whole pain experience. So we can start unpicking what actually is the sensation of discomfort right now. If we really pay attention and bring awareness to the body and the felt experience in the body, and what right now is worry or fear, or my heart's beating, or I'm panicking, or I'm thinking about the future. So mindfulness is it helps us to teach that skill of coming back to the present data. And for the neuroscience geeks in the room, if anyone's interested, I can put it on the group later, but there's a really good discussion between Sam Harris and Chamil, I can't remember his surname, but he's developed Google's Big Mind. And it's really about how and why mindfulness might help if you look at how the brain works, AI was based on this kind of predictive processing of the brain. And what we understand is that because the brain's continuously trying to predict what is the most likely thing right now, what is the most accurate analysis of the data, it's always going to be referring back to the previous data. And we know that the brain will weigh, from a statistical modeling point of view, it will weigh that previous data more heavily. When we start practicing mindfulness, we're actually paying attention to incoming current data, and that focused attention on the current data shifts that, it's called the Bayesian principle, but it shifts the statistical modeling, it shifts the weighting so that the current data is weighted more heavily. So you're actually able to see more clearly what actually is happening right now. So that's just more, if you really want to understand more of the neuroscience, what's actually happening when we're learning to pay attention, that's kind of what's happening. We're changing the modeling, we're changing the predictive processing, and we're changing how the brain is weighting the data. So, but that's just a little bit extra for the geeks.
Tracy also just wanted to add there, just made me think, like saying pain is contextual, and it does need a multidisciplinary approach if it's like the chronic, really embedded pain. But like things like sense of injustice will increase the likelihood of chronic pain. Workers' compensation cases often have a higher rate of developing chronic pain. So we also, mindfulness will help, but we also got to look at the social context And all of that,
Mm.
and are they embedded in community? And it's probably why an MBSR can work quite well for chronic pain, because you create that Sangha and community within the, within the mindfulness practices. So
And
just,
also what's not even on the slide is that mindfulness inherently elicits self-compassion. And we know from the research that people with chronic pain, that's often, there's a large part of that population that would fit under the categories perseverers, people that push through their pain, try and keep going as long as they can. And starting to cultivate a sense of self-compassion, we know if you just did a self-compassion 8-week program, we know that we're going to get changes in pain, intensity of pain, how often people get pain. And that's just working on self-compassion, because we know that it kind of softens I'm sure Lisa will speak a bit more about this, but it softens the whole nervous system's response and reaction. And then also taps into things like shame and guilt and all these drivers of the nervous system, trauma responses often, which are driving the nervous system into then more danger, making more pain. It kind of stops those neural pathways and starts building up an alternative, which is very much more safety making, gentler, compassionate, kinder. So mindfulness in general is something all three of us are very passionate about, which is why we're speaking tonight. Okay, go for it, Ivo.
so just a little video. It just really highlights how the brain processes pain and sensation, and how you'll see how it can be tricked even. So it's really good at creating experience and the experience of pain. So you'll see very clearly in this video how pain is not a sensation. It is really an experience created by an output of the brain.
The sound's not on here, Ivo.
Just going to stop share and then just share with.
We're going to do a little demonstration here called the rubber hand illusion. It's going to be a little scary.
This illusion may look like fairground fun, but it reveals one of the most important new ideas in brain science.
Thank you. Right there. Good. And can you put this hand down right over here and just curl it up like the rubber hand's curled up a little bit? All right. Now, what I'm going to do is try to position the rubber hand so it looks like it's your own.
Okay.
Okay, could you imagine that being your own hand, kinda?
Yeah.
What we're going to do is we're going to stroke your fingers simultaneously, the rubber finger and your real finger, and hopefully this will convince you that the rubber hand is your own, that your brain will actually adopt this hand.
In the illusion, simply watching the rubber hand being stroked at the same time as the real
happening again?
hand is enough to trick the brain into adopting it as its own.
We like weird. And slowly but surely, you should feel that the hand you're looking at is actually part of your body.
Feels like you're touching my hand with that one.
Right, so it feels like this is your hand that I'm
Yes.
touching, right?
Yes.
You okay?
Yeah.
Good. Try that at home with your kids. Yeah. The rubber hand illusion is a wonderful example of how multisensory perception can influence how we perceive our own body. I mean, that's how deep multisensory perception runs. When you hold your hand out, it's generally thought that you know it's there because of the information you're getting from your muscles and your tendons and that sort of thing. But what the rubber hand illusion does is show how that can be overridden by visual information. Okay,
The rubber
here comes
hand
your fun
illusion
surprise.
shows the powerful connection between what we see and what we feel. But it reveals even more than simply the way our senses are connected. It hints that a fundamental change in the brain is taking place.
Oh,
Isn't that strange?
yeah, that's creepy.
So what might be going on in the rubber hand illusion is that the brain is actually changing to accommodate the new rubber hand, going through some sort of, structural change that we call neuroplasticity. Okay, I'm gonna ask
Neuroplasticity is an exciting new idea that suggests the brain can change in response to experience. And this is what's taking place in the rubber hand illusion. The brain may be temporarily rewiring itself to adopt the plastic hand as its own.
Really feeling like it's your hand now, huh?
Yes.
Is that a little weird?
Yes.
Yeah, we like weird in perceptual psychology. There we go. Was that scary?
Yes.
Good, we like that.
Okay, so that just sort of shows how in the brain it actually starts to have the experience of this rubber hand as being itself. And even if he was to um, stop touching the real hand and just touch the other hand with the brush, the person would still experience the sensation of the brush. So our visual system is also an important part of pain reprocessing. Yeah, let me invite, so I'm going to spotlight Lisa, me, and Tracy. And we just going to
Should we
go
just,
through a
do you
little.
want to, should we just take some questions first before we go to the next?
Yes.
Yeah, just questions about the presentation. Just to take some space for that. Any questions or comments?
Me?
So my question really is, I understand this in relation to chronic pain. But when we work a lot in palliative care with patients in pain, obviously, that whole part of making people feel safe is one aspect of it. But there is another aspect where sometimes, the pain is just painful. So, it's this sort of dance is that sometimes there's something which is very painful, as well as the way in which we then interpreting and perceiving and being with that which is painful. It's kind of both of those things.
Yeah.
Janine, pain is always pain. If something is painful, it's painful.
Yeah.
That's the actual take-home message. It's not, is this chronic pain? Is this acute pain? Is this pain caused from cancer? Is this pain caused from actual tissue harm? At the end of the day, pain is an output. So if you're experiencing a 10 out of 10 pain right now, it's a 10 out of 10 pain right now. The job as the palliative care provider is to work with that person to look at, I know in cancer care they've got social pain, they've got spiritual pain, they almost talk about it in different ways. But I actually spoke at the oncology conference last year and said it's actually not that helpful to talk about pain in those different ways, because what you're saying then is that, well, there's physical pain, and then you've got spiritual pain, and then you've got social pain, and then you've got existential pain, and actually it's just pain is pain. And it's actually very simple. It's just literally, is there more danger going on in and around me? And that's why the protector meter is quite helpful, because it's beliefs, thoughts, people in my life, places I'm going, my worries and concerns. Am I going to die? What does this mean? So it kind of if you can take on an updated model of pain neuroscience with palliative care, it's more accurate, and it's actually more validating, I think, of someone's pain experience, because what we tend to see in palliative care is that there's more emphasis placed on physical pain than there is on spiritual pain. But actually, pain is pain. So if the person's in 10 out of 10 pain, but you as the palliative care provider understand that there's a large amount of spiritual angst that's going on, obviously we want to support that and create safety around that spiritual existential threat that is in that person's life at the moment, as opposed to maybe pumping up their morphine in that moment. So it's going to be experienced as physical pain, as in this, I have pain in this part of my body, but the real skill of the provider is to start finding out through talking and understanding what is playing into this, what's leaning that system more into danger. because it is painful. But obviously we don't want to always necessarily go, oh, well, they've got cancer, so we've got to just keep pumping it, because as you know, it gets to a point where the morphine stops working, and so then what? Well, there's nothing more we can do. So that's why I think, and that can be very fear-making for the provider, which is going to drive into the system as well, make more threat. Does that make sense, Janine? And sort of understand, just sort of changing it a little bit to understand that it's multidimensional.
No, I mean, I think palliative care is the one place where we really do understand the multidimensionality of pain and the perception of it. I think what I'm just saying is that there is an aspect at which there is physical pain too. And so that it's not just about looking at all of those other aspects which are going to increase your perception of what's happening. But there is another aspect that there is something that is happening. So that
there's always something that's happening. And I think that's so
that you need to get on top of that with
yes.
more.
So treating the pain is
to be able to, for the patient and the families to feel safe.
Definitely. So I think having, I mean, post-operative pharmacological management, and for me, palliative pharmacological management is the cornerstone, because that's what's going to create safety.
So you don't want to get into those pathways, of feeling like I'm in pain all the time.
Definitely. And we know that not treating that post-operative acute pain can actually create more of like a chronic pain later on. So treating acute pain for me, or acute post-operative cancer pain, is super, super important pharmacologically, because it actually calms the whole system down and it doesn't ramp up the system. But as I say, I think it's just kind of understanding pain is pain, and then as a provider figuring out what pharmacological intervention is most applicable now, in this moment. Is it an anti-inflammatory? Is it a morphine? Is it a SNRI? Is it a tricyclic? So just knowing the mechanism of the pain and understand what might be going on is very, very important. So that's why I like to work, as Ivo says, in a multidisciplinary group, because I'm not a prescriber, but that's often my first port of call, is to get the pain under control pharmacologically, if it's more acute or palliative.
Yeah, I also find that working as a physio in the hospice is that first get that under control, because that will create a lot of safety already and a lot of control in the patient of their pain, and that really made them feel safe. And only after that started working is to actually start going like, okay, how can we now look, that there's some pain still left over, there's still some fear, then we can start to work with that, because without that base level, they're just not going to be able to even focus enough to hear your words. Thank you for bringing that in, Janine, because I think that's really important. That is one of the big arms of chronic pain management.
I just would like to say that, perhaps maybe where the main focus of this presentation, could lie is with chronic pain that is not necessarily at that stage of life. Like somebody who's living with chronic pain, for a few years, many years, and there isn't that immediate threat. So then, what is the picture we're looking at then, where you actually get the information and the feedback? No, you're actually okay. There's nothing really going on here that we can describe with accuracy. And then it's then what? And I think that, like many of the practices that we are going to talk about and address are incredibly powerful for that particular just group of people who dealing like at that particular stage of the journey.
And just to add, for the sort of palliative care, I found that open awareness practices are quite resourcing. Like, we're not worried about spiritual bypassing, we're not worried about them. Like, they need a resource where they can sit in. And I find the open awareness practices give a lot more space and they're sort of going there already, right? If they're in the dying process. And I find that's a much better in than going to the body, which is feeling quite traumatizing and quite betraying. So those open awareness practices can be quite resourcing for people who are in in hospice care and end-of-life care. Simon.
Hello, everybody. I'm not sure if this is the particular juncture in this discussion to bring this in, but I'll drop it in and you can say whether we can just pause around it. Sorry, it's telling me, looks like you're done talking, so we'll lower your hand in 3 seconds. Zoom is telling me I'm done talking. Maybe it's predictive AI knows that I'm done before I've actually said anything. So what I want to do, this is something that I've been exploring very recently and has really, really struck me. Jaap Panskep's work, who some of you will be familiar with, the emotional centers in the brain, the 7 emotional centers in the brain, and what has been described by Panskep and others is that we've got 2 alarm systems, not 1. So it's most of us think of the alarm system as the fight or flight, the fear-driven system, and amygdala predominantly, but also other areas in the middle of the brain in particular. So, but how he describes is that that's the one alarm system, and that's related to external threat. But the other alarm system is the panic separation system, which is related to relational threat and relational trauma. In as much as that's an infantile, evolutionarily active emotional center. As an infant starts becoming mobile, it's still wholly dependent. It's always looking, where's the mother, where's the caregiver? But if the caregiver isn't around, that panic separation system starts to activate, and it's almost like an internal alarm or a relational alarm. And what was interesting, if you look at the areas, and I can't remember, so that's predominantly the anterior cingulate cortex as opposed to the amygdala. But what they share in common is they both activate the periaqueductal gray, which is like the grand central station of pain processing. But it really strikes me, and I just wanted to drop this in. It's very new information for me, and it was coincidental. I was reading this review article this morning with this evening's talk presentation happening. And I was wondering, what is this connection here with mindfulness and the way we practice it as a community and the way we teach it and the way we want to share it is we place primacy on relationality. And you using the word safety, what makes somebody safe? I'm not sure opiates would mimic the safety of relationship because the primary neuropeptide receptor upregulation is opioids in relational safety. Oxytocin to a lesser degree, but predominantly opioids, which is very, very striking. So I'm just wondering whether people use opioids because of their relational trauma, and whether what we talk about here in safety, first and foremost, is a relational safety, because that's usually the hidden trauma that almost everybody carries and then gets exacerbated and intensified with other elements of trauma. So I just want to drop that in because it's so much part of the relational mindfulness that we all practice. And again, these are unformed thought forms that I'm having, but it feels like it's highly relevant to what we're speaking about. So maybe, Lisa, maybe all of you, when you speak about your next phase of integrating mindfulness, how does the relational field, the attuned mindful of other, mindful of self, that relational field, how does that show itself, and how do you notice that affecting your patients, your clients' response to stress? To pain or stress, you can call it the stress of pain.
Yeah.
Yeah, I definitely think it's in that relational field where a lot of pain relief happens, just with people, mirror neurons and people being able to access that through you. Just by that holding space. And it reminds me of that experiment where they put a rat in a cage with morphine and water, but they put it alone, so it became addicted to the morphine. And then the one person said, well, is that because morphine's addictive, or is it because of the context? And then they put them in rat heaven, where they had slides and lots of friends, and they actually started going for the water. So it sort of showed that connection part of being together. They didn't go to the morphine because they're like, I'm getting this from the relational field and the context I'm in. And I think that's quite applicable to pain as well, is that if you can create the context that creates safety in me, then, and with relationality as well, with safe attachment, which often a therapist or physiotherapist will mimic and hold, or not mimic, hold for you, so that you can actually start to see, oh, wait, that's something I can also tap into.
Yeah. I mean, I definitely.
So you talk about a holistic, and I'm just wondering, the holistic often represents somebody feeling seen and heard.
Exactly. So that's what I want to say, is that for me, it's like that, like a therapeutic alliance is a huge part of this process. So it's really like being like very attuned, very, very interested, working together with someone to explore what's going on. And so there's that sense of we are creating a safe space together to explore this very hard experience that you are going through. And then, and this is going to, Tracy will pick up on this just now, but one of my tasks is how can I support people in learning to find safety inside themselves? So whether that is through, creating this like safe relational field between us, or doing the self-compassion work, which slowly engenders in us this capacity to amplify or to touch or to drop into a sense of internal safety. That's a skill. And it's a skill, the lack of which comes from the root of exactly what you speak about. That later on we maybe need to relearn these inner relational capacities, and obviously the outer ones. And that is where the mindfulness is so powerful, is that when we as practitioners practice from that place, that we know what that is, to be seen and received in that space. So I don't know, but I think it's it's very powerful what you're pointing
I
to.
think there's so much research into the impact of adverse childhood experiences and adversity in childhood and attachment trauma and the incidence of chronic pain later on in life. So it's really interesting. Thanks, Simon, for sharing some of that latest stuff. I'm going to go and search that up, but it makes complete sense. We're going to need to move on because I'm just looking at the time. Lisa, and I'm just thinking we were going to do you were going to tell us a bit about your story, and maybe you can do that, and then we can move into a practice, Lisa, that you'd like to share with the group.
Yeah, so just for the sake of time, I just thought I would share with you, it's nice to hear from personal experience. I had about 5 years of chronic pain, and Tracy and Ivo don't actually even know the story, because we decided we would just leave it for me to tell you all, and you will see what resonates from what we've spoken about. But just suffice to say that I developed chronic pain some months after my father passed away. And it started off, in fact, Simon, we were running a retreat together when I got terrible lower back pain. It was excruciating. And I couldn't believe it. I was holding this retreat and having to, just this excruciating pain. Anyway, what happened is that I started going for some physio, and it didn't really help. And then the other side got sore, and then the other side got sore. And then suddenly I found myself a couple of years in, this was like slowly growing, not only dealing with this loss, but also dealing with this incredible ramping up of stress in my work. I found myself with just pain exploding all over the place at strange times, not in relation to anything. Nobody could find anything wrong with me. I went twice to the neurologists. I went to the rheumatologists, and it was really the two things happened that sort of got me onto the path. The one was being diagnosed with central sensitization by a physio that I saw, and she introduced me to this idea of how my pain system had become oversensitized, and that sensations which normally would be kind of benign or just experienced a sensation had actually become so strong in me and they were being perceived as pain through this amplification. So it's like the alarm system you know, you don't want it to be set off every time a butterfly goes past, you know, so it's like it's like high wired. That was the one piece. And the second piece was that the rheumatologist, I was I feel very grateful that I wasn't given a diagnosis, because she said to me, she said, I think you are incredibly stressed. I think your body is holding an incredible amount of stress. And I was like, I laughed at her. I said, are you joking? How could the stress cause? And she said, explore it. And so I went on a journey. One of the modalities that I now share was the practice. I did it every day for about 9 months. And it was now looking back, and we you know, this is where it ties into our presentation. We can see mindfulness as a top-down approach, where we use our attention, we use our mind, we use direction from the top to work with pain skillfully, to inquire, etc. All the things that we know about our mindfulness practice. And so for me, what was healing was this bottom-up approach. Is that it was the relaxing and softening of the nervous system. As my nervous system released this muscular held tension, as things just felt easier and easier and easier in my body, everything just rewound, and you know, my pain system returned to normal is how I understood it. And so, you know, for me, what was very interesting is asking the question, why was mindfulness not enough? And it wasn't enough for me. You know, I've been practicing mindfulness for 20 plus years. It wasn't enough. That capacity to sit neutrally with what was going on wasn't impacting the experience I was having. It didn't impact the sensitivity of my pain system. Yes, I could see this is a sensation. This is an unpleasant sensation. But ultimately, I was caught in something. I was trapped in something. And so for me, that's why, you know, this holistic, Simon, it's relational. It's working with mindfulness. It's working with nervous system regulation tools. It's being it's like, you know, what is the next appropriate exploration for somebody, you know, who is with you. And so that was my story. I don't know if you guys want to, you know, we said we'd have a bit of time maybe to you know, for them to make some some comments or thoughts. I mean, we've running a little bit short, but there we go. That's my story. What do you make of it, guys?
I'm just actually curious, Lisa, what was your aha moment where you were, was it your rheumatologist saying, go and explore this, or was it knowing wholeheartedly that there isn't something structurally wrong with me? Because it sounds like you were on a bit of a journey to find out what was going on and you were worried about that. Yes, and yeah, I'm just curious about, you know, how you were sitting with it before that moment in mindfulness and what was coming up for you.
I mean, I had really catastrophized myself to the absolute nth degree. You know, really, it was such a journey. Please tell me the thing that's wrong with me. You know, just please, just tell me the terrible thing. And you know, and luckily in my case, there wasn't a terrible thing. You know, and I had to come to terms with that. And that is a big point in a journey for everybody who faces this, is at what point can you tip over into the recognition, acceptance, acknowledgement, belief, actually, I'm not damaged here. I don't have MS. You know, and no matter that the fact of my symptoms are behaving like someone who might have that is not what is going on here. What is going on here? And so, yes, that was a very important part of my journey. And I think it's a very, you know, it's a tricky place for everybody, because as you were saying, Trace, the knowing, actually, there's nothing seriously wrong here. Yes, it's not nice. In fact, it's hideous. It's traumatic. It's traumatizing to be in such a state. But there's nothing structurally wrong. I'm not damaged. I'm not broken. Something here is out of balance, and there are ways to bring it back into balance. So yes, that's my answer to that.
Lovely. So Liz has asked if you're going to share the practice that you did for 9 months. Would you
Yes,
would that be an okay time to share it, please?
Yes, so it's a very small niche little practice. It's called Hanna Somatics. That's the name of the person who developed the work, Thomas Hanna. And I studied a branch of it called clinical somatic movement. But it works with the idea of sensory motor amnesia, that our brains and nervous systems get stuck in sympathetic activation, or freeze or fight or flight. And whether this is internally or externally driven, and it gets held there. There's like an ongoing unconscious holding, and that becomes very difficult from someone on the outside to help you release. So if somebody's, so like I would have a lot of massages, and go for physio, go for chiro, all these sort of external approaches. And this approach, it's movements that you do yourself. And I'm not actually going to go into too much of it now, but just essentially it's like it's a neuromuscular re-education. So inside yourself, through doing this movements, you make that change of just telling the nervous system you can let go, you can let go, you can let go. And yeah, there's like a slow healing process, because it definitely it felt like a healing.
Lovely. Thanks, Lisa.
Lisa, I was also interested to, like, this process, and it's like it's not this magic bullet that you suddenly have the belief and the pain goes away. So I'm just interested in that sort of, like, because often we talk with chronic pain patients about, like, you may have a flare, it's a bit of a journey that's like this. So can you talk a little bit about that process of, like, uncovering, and maybe how mindfulness, like you say, it was a container that gave you a skill to be able to, access the somatics and all of that.
Yeah, definitely. I think that, it's such a, it's such a like a cyclical journey, and it is absolutely not linear. And you're working with so many, like on so many multiple different levels. And maybe this is the time to just briefly talk about the pain reprocessing therapy, which is actually a modality that I only came to afterwards, after I had recovered from the chronic pain. I suddenly became, as the algorithm does, sends you information. And I suddenly became aware of this work where, it described so perfectly this experience that I'd had. And what this work does, it's a top-down approach, which helps one reappraise experientially in the moment, learning the skill in the moment to reappraise the pain sensations, but not merely through the lens of mindfulness, in combining both the mindfulness, because the mindfulness is foundational, and at the same time finding ways to send messages of safety to oneself, whether they are spoken words, whether they are touch, whether they're gestural, whether they're sensory, having something comforting. So it's like it's an extra, like an adjunct, you could say, to the mindfulness practice, because there needs to be a little bit extra effort or care taken to really establish the space of safety that we need to work with the pain system in this way.
I think it's also just important to note that often, having been in chronic pain for 5 years or 10 years, or having had an illness that's not been diagnosed, no one is able to tell you what's been going on. That in itself is very danger making and traumatic. Plus, then, if there's an underlying history of adversity or prolonged stress growing up, and so the nervous system is naturally going to be biased towards insecurity. And it's naturally going to be biased towards identifying and recognizing danger cues. So the system is so much more leaning towards identifying where the danger is, that it does, as you say, like concerted and focused attention and effort needs to be given to find these safety cues and play around with them a little bit. Because the thing is with pain reprocessing therapy and brain training and all these various interventions is that if it feels like almost like yet another thing I should be doing and then I'm doing it wrong, it quickly becomes a danger. So even something like, which we all think would be lovely, yoga, beautiful. Even, I haven't done my yoga practice or I'm doing it incorrectly, even that can become a danger-making activity. So I think that with all of these, whether it's mindfulness, whether it's brain training, whether it's pain reprocessing therapy, for me, it's got to be embedded in a sense of safeness, relative safeness. And for me, that comes from really what Simon was speaking to, which is not just relationality to other, but relationality to oneself, for me, is key. Because what tends to happen is we almost can, our own conditioned responses through our attachment system can spin us into blame, guilt, shame, which are all going to be driving that danger, the sense of danger within. So for me, the self-compassion practices, which we all know, all of us as mindfulness teachers, we know that. So that's maybe something that as a group, we can all start recognizing and perhaps offering our clients, because that, I think everyone in the room has been taught about self-compassion, but now perhaps understanding why that might be so helpful in the context of pain. That, I don't know what you guys think, Ivo and Lisa, but that could be something as like a first port of call, because obviously not everyone knows about pain reprocessing and somatic tracking and things like that. But self-compassion for me is a low-hanging fruit, as my one colleague likes to call it.
And I think it's so simple to give to somebody. It's just that thing of like, it doesn't even need to be a big practice. It's just like, giving yourself a hug and holding your hand on the heart. And those very simple regulation practices are at least a starting point for a lot of people that are very accessible. And I think, us as mindfulness practitioners and therapists working in the field is sort of mirroring that and sort of showing people and being vulnerable about our experiences of dealing with pain and going like, I've also had to deal with certain things and I've also had to go on that journey. And when people feel like you're going on a journey with them to discover what works for them, it's not this prescriptive thing that you're just giving them. It's really this thing of let's uncover it together, which I think is a lot more of an open field. And then that compassion comes out of that because you're like, see, we're two human beings trying to figure this out, trying to be with each other in this journey that you're going through with chronic pain. I think it's so important to really bring the humanness into that.
Yeah.
Maybe we should go into practice.
Yeah, practice. Trace, why don't you take us? Let's do the self-compassion. Seeing we're talking about it. Let's start with
cool.
that.
All right. Yeah. So we've got 15 minutes left. So I'll do a little really short one, just so you guys can get a little bit of a taste of how I would incorporate a self-compassion practice into the experience of physical pain. So maybe just for all of us sitting, we can just do it together. You don't have to look at the video as long as you can maybe just hear the guidance and we can see how it all goes. So just getting comfortable. As I say, if you want to move away from the video, feel free to do so. Just taking some time to take care. And just perhaps anchoring your mind and your body however you best know how. And just taking some time just to feel into the present moment, whether it's through your breath, just the feeling of your sitting bones touching the chair. Maybe it's the feeling of your hands clasping together. Whatever it is, just taking some time to identify something that's just going to help you and your nervous system know that you're here. And for some people, they prefer to close their eyes when they do this practice. Others prefer to keep them open. You can change your mind halfway through. I'm going to be guiding it with my own eyes closed just for the next few minutes. And we've been speaking about nervous system regulation, activities. And so for some people, they do find that taking a little bit of an extra deeper breath than usual can be helpful. You might want to try that out, see how it feels. Or if not, just continuing as you were. And we're going to be doing a little RAIN practice, which I'm sure you're all very familiar with. RAIN being R-A-I-N, an acronym standing for recognize, allow, investigate, and nurture. And we're going to be doing this in the context of physical pain. So just taking a moment to bring to mind or notice right now in the body something that is difficult for you right now. So it doesn't have to be physical pain. It can be more of a difficult situation, but because we're doing a little learning forum on physical pain, maybe your body's giving you a little gift right now and you've got something that you can work with. So maybe just do a little body scan and just notice what's going on in your body right now. And just see if there's anything that you feel you'd like to work with that feels physically uncomfortable. Maybe it's a little bit of a headache, a little bit of discomfort from indigestion. Maybe it's a bit of back pain. Maybe you've got some pain that is very familiar to you. And if you can't identify anything right now that feels physically uncomfortable, then perhaps just bringing to mind something that right now is challenging for you, that's difficult, and maybe even painful on a more emotional level. And just recognizing it as painful. And then A is allow. So this is where we really just take a moment to ask ourselves, can I allow this painful experience to be here right now? And really asking that to yourself. And you might decide, no, I'm not really wanting to work with this. I don't feel like I have capacity to work with this physical pain or this emotional pain right now. In which case, maybe just open your eyes and you can even walk around the room and just take a little break and come back to the computer in about a few minutes' time. But perhaps you feel you are willing to work with this pain for the next few minutes, in which case, yes, I can allow this to be there. So we move into I, which is investigate. So for just the next few moments, seeing if you can let go of the word pain and seeing if you can investigate it as an unpleasant sensation. It's noticing when you bring this experience into awareness, what actually is the sensory data that you're receiving? What is its quality? Is it sharp, stabbing, constricting, digging? Does it have a color? Are you able to sense in the body where it's being experienced, noticing its shape and its borders, where it starts and where it finishes, how deep into the body it goes? Maybe it's got an image. And as you're investigating it in this kind of way, noticing if there's an emotional reaction or a feeling tone associated with this difficult and unpleasant sensation. Maybe a bit of worry, sadness, frustration. Anger. Or perhaps your mind is going to something about this pain. Is it ever going to go away? Will I be able to cope? What does it mean? Just seeing if you can bring awareness to the entire experience. And then seeing if you can almost, it's a little bit like looking for treasure. Seeing if you can broaden your awareness and move beyond the borders of this unpleasant sensation. And see if you can find something in the body that feels helpful, resourcing, or maybe even just neutral. So it could be going back to your anchor, whatever it was that you chose in the beginning to ground your attention to the present moment. Or it could be something else that maybe a gesture, as Ivo said, just something, maybe you touching your hands, something that feels good in the body, pleasant. Just allowing your attention just to settle on that sensation, noticing the feelings of, or the sensations of pleasantness that might be there. Softness, warmth maybe, lightness, openness. And then moving back again to the difficult sensation. And just sort of seeing if you can just stay at the borders for a little bit. Just staying at, almost feeling how the resourcing part of the body is being almost escorted towards the difficult sensation. So it's almost like it's holding the difficult part. And just noticing what's there now. Maybe the sensations changed a little bit, the quality may have changed, the intensity might have changed, for the better or for the worse. Without labeling it, just noticing if there has been any change. And again, just recognizing what's there right now. And having gone through this practice, moving on to the end now, which is nurturing, just seeing, knowing and understanding and having investigated how this difficult experience is presenting itself. How would you want to nurture yourself as you move into the next part of your evening? And if that's difficult to answer, maybe thinking about, well, how would you be if it were your loved one that was experiencing the same difficulty? What might you offer them? You might suggest that they have a hot bath, or you might give them a hug. You might give them some loving gestures or words. And so the invitation is to see if any of that is available to you right now. And to see if you can carry some of that self-compassion and nurturing into your next phase of this evening as you settle down and start making your way towards your sleep time. And if your eyes were closed, you can open them again. And that is a rain practice in the context of physical pain.
Beautiful. Thank you.
So we are coming towards the end. And I know Ivo wanted to finish off with a no, or maybe just you can read the poem again. I'm just wondering if there's anything that's come up, or if anyone wants to ask anything or share something that came up for them now.
I just want to add something, Trace, to your practice. We were going to share a somatic tracking practice, but in essence, that was a somatic tracking practice.
Hmm.
The only thing that I'd like to put as, just put into the picture for people who literally cannot sit still, like cannot sit with their pain to even go through a process like that. That's where the somatic tracking in like small 30-second bursts sort of thing can be very helpful. And that is a similar kind of process, establishing, a sense of safety in the room, safety between us, something soft and comfortable, to connect to. And then inviting people to be with the pain sensations just for a little bit of time. And can they also bring in a message of safety? So yes, I'm feeling, this very intense sensation. Can I just remind myself that I've been given the all clear, like literally down to that sort of specificity, that doctor told me I'm actually okay. And, and also then this idea of just coming in and out of the practice. So really being with someone in this very in and out kind of way until they've built up a little bit more capacity to sit in experience without panicking.
So I think we're coming to the end. Thank you everyone for joining us. Yeah, I put that, somebody asked for the Sims-Dims diagram. I put a PDF up there. So if you want to download it before we end off, it's just sitting there. So if you want that diagram, it's there. Yeah, I sort of feel like this could have been a 2-hour session. There's a lot to unpack when it comes to pain and mindfulness and all the different tools that can be used for it. So maybe let's just end off with just hands on heart, just saying thank you for this community that has joined us tonight. We're always happy to share with all of you. And keep well and have a lovely evening further. It was so lovely to be joining you this evening.
Thanks, everyone.
Good night,
Thank
everyone.
you.
Thank you, everyone.